Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Nature is flawless, and we are inspired by this perfection. We blended the sharpest vision in nature with modern technology. We inspire people to see better. Nature is flawless, and we are inspired by this perfection. We blended the most agile, flexible movements found in nature with modern technology. We inspire people to move better. We selected the most spectacular details to inspire people to live better.
VSY Biotechnology. We inspire.
Buenos días. De nuevo estamos en ARI24, sesión 11, un tema importantísimo, glaucoma para cirujanos de catarata. Una pesadilla quirúrgica, ciertamente que cuando tenemos un paciente que tiene un glaucoma y una catarata es un paciente diferente. Es un paciente que tiene distintos retos, que tiene distintas posibilidades de abordaje y finalmente tiene una gran oportunidad de mejorar tanto de visión como de control de su presión intraocular. Tengo el gusto y el honor de compartir esta sesión con José Martínez de la Casa, querido amigo y gran experto en glaucoma, y con una serie de paneles de expertos que vamos a llevar esta sesión para que sea práctica para aquellos que tengan que abordar estos pacientes siendo cirujanos de catarata. Quiero dar las gracias a Carl Mersirka, a André Tatam y a Pepe Belda, que van a participar con nosotros junto con un panel de debate en el cual estarán Julián García Feijóo y Lucía Rial para compartir este momento y esta sesión tan interesante sobre un tema tan frecuente. Así que vamos a presentar primero una introducción que va a hacer José Martínez de la Casa sobre el glaucoma para el cirujano de cataratas, qué es verdad y qué es lo que funciona. Adelante.
Hola a todos, muchas gracias por atender a esta sesión de glaucoma y catarata que tengo el gusto de moderar con el profesor Alió. Esta introducción, que va a ser una presentación muy corta, es acerca del glaucoma para el cirujano de cataratas, qué es verdad y qué es lo que funciona. Estos son mis conflictos de interés. Y bueno, la primera consideración importante que tenemos que hacer es si estamos ante un glaucoma de ángulo abierto o estamos ante un glaucoma por cierre angular, porque los abordajes van a ser completamente distintos. Si empezamos por el glaucoma por cierre angular, aquí es donde la extracción del cristalino va a tener un papel más importante, porque en muchos casos nos va a permitir controlar la enfermedad. Para saber más acerca de esta extracción del cristalino tenemos que irnos al estudio Eagle, que fue un estudio randomizado y controlado que analizó la efectividad de la extracción del cristalino transparente comparado con la iridotomía periférica en pacientes mayores de 50 años que tenían pues un cierre angular con presiones elevadas o ya un glaucoma por cierre angular, y que demostró que la extracción del cristalino transparente, incluso el cristalino transparente sin catarata, pues era más eficaz que la iridotomía periférica para el control de la enfermedad. Además, un posanálisis de este estudio Eagle nos demostró que si esta extracción del cristalino transparente se realiza de forma precoz, pues los resultados van a ser mejores cuando hay poco daño estructural, poco daño funcional, e incluso cuando los pacientes pues aún no tienen presiones elevadas, pero todavía no tienen tratamiento. Con lo cual, bueno, pues un mensaje importante es que esta extracción del cristalino en estos pacientes con cierre angular pues debe realizarse de forma precoz. Las conclusiones de este manejo por cierre angular sería que siempre que tengamos una catarata en un paciente con un cierre angular, con presiones altas o un glaucoma por cierre angular, pues la extracción de la catarata lógicamente va a ser el primer paso para ver si somos capaces de controlar la enfermedad, pero que incluso si estamos delante de un paciente con un cristalino transparente que sea mayor de 50 años, que tenga un cierre angular con presiones por encima de 30 milímetros de mercurio o que tenga un glaucoma por cierre angular, pues la extracción de ese cristalino transparente va a ser el primer paso para ver si controlamos la enfermedad, y si no, pues ya tendremos que recurrir a una cirugía específica de glaucoma. Si estamos delante de un paciente con un glaucoma de ángulo abierto, aquí el abordaje es completamente distinto, porque la extracción del cristalino va a tener un efecto muy residual sobre la presión intraocular, entonces tendremos que recurrir a otras estrategias. Si el paciente tiene un glaucoma incipiente y no tiene catarata, pues posiblemente sean los láseres, la trabeculoplastia selectiva o en el futuro el láser de femtosegundo, que nos permite realizar una trabeculostomía con el ojo cerrado, pues podrían ser una opción para intentar controlar la enfermedad en estos pacientes. Y si ya tenemos ese mismo paciente con un glaucoma incipiente pero con una catarata, pues la cirugía de la catarata nos va a dar una ventana de oportunidad para recurrir a algunos de las técnicas quirúrgicas o de los dispositivos que tenemos disponibles, ¿no? Los mix trabeculares. Posiblemente el iStent es con el que tenemos una mayor experiencia y evidencia acerca de su eficacia y de su perfil de seguridad, y sabemos, bueno, pues que asociándolo a la cirugía de la catarata vamos a poder conseguir o enlentecer la progresión de la enfermedad. Helios, el láser steamer, para la trabeculostomía con láser steamer podría ser una alternativa sin implante al iStent inject, porque también la eficacia podría ser muy similar. Ahora mismo hay un estudio randomizado en marcha comparando iStent inject con Helios, y el perfil de seguridad también es muy bueno. Y luego tenemos otra serie de cirugías trabeculares que ya serían más específicas para cirujanos de glaucoma, puesto que tienen una curva de aprendizaje mayor y también tienen potenciales complicaciones que no tienen las otras cirugías que les he mencionado, por ejemplo Hydrus, o las canaloplastias como Omni y iTrack Advance podrían ser alternativas para conseguir mayores descensos de presión intraocular. Si estamos delante ya de un paciente no con un glaucoma incipiente, sino con un glaucoma moderado, tanto en un escenario de cirugía combinada como en una cirugía aislada, pues los implantes formadores de ampolla, como pueden ser el Senel Pressure Flow, pues pueden ser muy buenas alternativas incluso a la cirugía filtrante convencional. Son cirugías seguras también, lógicamente tienen un perfil de seguridad o tienen potenciales complicaciones mayores que los mix trabeculares, pero también nos van a dar un muy buen control de la enfermedad que puede ser incluso comparable al de la cirugía filtrante, y ya hay varios artículos que ponen de manifiesto pues esta gran eficacia de estas técnicas.
Okay, thank you very much. José has been a very nice introduction to a very interesting session. And now the next speaker is from the United Kingdom, Karl Masierka. He will talk about trabecular mix with implant, stent inject of Glaukos and Hydrus from Alcon. You are the next. Thank you.
Hello, dear colleagues. In the next 8 minutes, I'll be speaking to you about trabecular meshwork bypass stents, a non-filtering form of minimally invasive glaucoma surgery. Now, over the last decade, we've seen an explosion of options for us in the glaucoma field, and we are not restricted to just prescribing drops and doing some laser, and then on the other hand, doing trabeculectomies, tubes and deep sclerectomies. But we've got multiple options at every stage, and trabecular meshwork stents fit this area here, where we have, of course, not as effective an IOP lowering as a trabeculectomy, but much, much more safety. As an overview of the two currently available stents, the iStent is known for over a decade now. It's gone through an evolution from the G1 to the Inject and now W. The iStent is about 1 millimeter long and has a 0.12 millimeter lumen. You can see how small it is in the pictures here. You can see how it's evolved from a snorkel-looking stent to a more straight injectable device, which has also changed more recently, a couple of years now, with a larger flange giving more stability and less chances of under or over injecting. You can see in these videos the evolution again of the iStent over time, with the G1 on the left-hand side, iStent Inject in the middle, and then the larger, wider, if you want, flange stent on the right-hand side. The second currently available stent is the Hydrus stent. This is made of nickel titanium. iStent is titanium. Both are non-ferromagnetic. Hydrus is 8 millimeters long, so it's longer, a bit like an eyelash, I tell my patients. The lumen is also similar, but you have 3 of them. And besides bypassing trabecular meshwork, you also have these windows which essentially scaffold your trabecular meshwork and keep it a little bit more firm. You can see from the video as well that the technique is a little bit different. We are not injecting here. We make a very small cut in trabecular meshwork and then slide the stent in. Histopathologically, you can see how the Hydrus actually keeps your Schlemm's canal open, besides just stenting trabecular meshwork, which is more done with the iStent Inject on your right-hand side. How do we judge a mixed procedure? Well, for all mix, there are 3 key points: efficacy, safety, quality of life. Let's talk about efficacy. For iStent, we have a lot of randomized controlled trials. The pivotal trial by Samuelson on the iStent Inject is shown here, and you can see that for every measure, whether it is a drop in pressure, 20% reduction, washed out diurnal IOP reduction, a phaco combined with iStent achieves a lower IOP in significantly more patients. You can also see that from a pressure of around 25, we are achieving a mean pressure of around 17 in a washed out population with no drops. RCT evidence has also shown that the higher the baseline IOP for an iStent, for example, the better the effect. So if you have a baseline of less than 25, an iStent combined with a phaco will give you a little bit more pressure lowering than the phaco alone. But as we go towards higher baseline IOPs, that IOP drop is even more striking. The phaco seems to just lower the pressure by about 5 millimeters of mercury, irrespective of baseline. There's also loads and loads of real-world data with 5, 6, 7, 8, 9-year results. You can see from this diagram here, we're always achieving a good pressure-lowering effect of about 5 to up to 9 millimeters of mercury. We're achieving mean IOPs of between 13 and 15, and a large proportion of patients are off drops. Germany was one of the first adopters of MIGS, and in particular iStent, and we also have people producing 10-year data, like Neuhan here, 63 eyes. What's striking here is not only a pressure of around 16 at 10 years, but that over 30% of patients at 10 years are still off drops. Hydrus also comes with a large body of high-quality data. There are large randomized controlled trials, again with very large number of patients, over 500, with very, very high quality. Also Cochrane reviews showing that the data is actually very good. The Horizon study is the pivotal study for Hydrus, showing again, similar to what I showed you with iStent, that combined with phaco, as opposed to phaco alone, we have a higher chance of achieving a pressure reduction. And interestingly, over the 2 months, the 2 years, there's an increasing treatment effect. So the phaco effect seems to fade away, but in those patients with a Hydrus, that pressure lowering effect remains high. And this is what I tell my patients when offering them a phaco trabecular meshwork stent, that there is a better chance that their pressure is lower, a better chance that they are off drops. And if you look at medication-free patients in the Horizon data, nearly double have no medication at 24 months, and this big difference remains even at 4 years, where 65% versus 41% have no drops at 4 years. What about standalone? Of course, standalone stents do work. We have large now analyses, systematic reviews, not just prospective randomized trials, but also case series. So standalone is a good option, whether they're pseudophakic or phakic. And of course, this leads us on to safety. So how safe are these stents? Well, I tell my patients, if we're combining cataract surgery with a stent, it is basically as safe as doing the cataract surgery alone. We can see from the various studies that show that the risk of hypotony is zero, the risk of severe adverse events is basically zero compared to cataract surgery alone. Look at these slit lamp findings from the Horizon study. The amount of cell and flare after a combined procedure is the same as after a standalone phaco. What about endothelial cell loss? Whenever we're injecting a foreign body in the anterior chamber, we worry about this. But the pivotal trials are a bit reassuring. So, of course, in the phaco groups alone, we see over the trials, including the CyPass, which is a suprachoroidal stent, which is not available anymore, there is a degree of endothelial cell loss. With stents, that endothelial cell loss is actually not significantly higher. From this graph, you can get a perception that the iStent has the least risk of endothelial cell loss, in relation to perhaps the Hydrus here, where it seemed that the first days or weeks had more loss. And I'll show you a graph to try and explain this a bit further. So in the Horizon trial for Hydrus, even though there was an initial endothelial cell loss, if you start at 3 months and take the amount of loss over to 4 years, that is actually stable and comparable to the phaco alone group. So my feeling is that as long as you implant properly and you are as atraumatic as possible, the actual endothelial cell loss from the stent itself, whether it's an iStent or a Hydrus, is not higher or significantly higher than a phaco alone. If you look at the CyPass data, a suprachoroidal stent that was pulled from the market for endothelial cell loss because at 5 years it was clear how much more there was, and you look at the Hydrus data here, for example, you can see that the incremental decrease in endothelial cells is nowhere near what the CyPass had. Finally, last few seconds on quality of life. This is so important, especially in the early glaucoma patients who are using drops. There are patient-reported outcome studies here, for example, with the iStent. iStent group, phaco iStent versus cataract alone shows us definitely more positive responses over 24 months for the combined groups, both in VFQ-25 and OSDI, ocular surface disease scores. Also in terms of general health, general vision, ocular pain and driving, more positive outcomes with phaco iStent. What is real efficacy and quality of life, however? The ability to prevent surgery, glaucoma surgery. We see this from this Horizon data again, that people with the combined group with stent, Hydrus stent, had less chance of needing glaucoma surgery in the future. Same with a systematic review of all the iStents done. When we look at the rate of progression of ocular hypertension of glaucoma patients, and then the pink line, which is the ones with phaco iStent, the progression in these early glaucoma patients is so slow, which surely prevents the need for surgery. What's the future with trabecular stents? Well, there are more stents coming up. In the US, iStent Infinite is now out with 3 different devices, sustained release doses, combined canaloplasty and stents, and we need, of course, tests that show us which patients benefit most. If there is more you want to read about, there is a guide from the EGS on these devices. But in the meantime, I'm here to answer any questions you may have. Gracias.
Okay, thank you very much, Carl. Excellent introduction to this important topic of trabecular mix. And now we are going to have Andrew Tathan, also from UK.
To speak today. Here are my disclosures. The end of the 1960s was a time of innovation. It was the time of the first moon landings, but it was also the time when trabeculectomy was first described. And trabeculectomy has really been the main landmark in innovation in glaucoma surgery. Since first described, trabeculectomy has also evolved. There have been innovations such as releasable sutures, suture lysis, the use of antimetabolites, aiming to reduce early postoperative hypotony and reduce late postoperative fibrosis. But with a powerful IOP-lowering procedure, there are risks, and some patients develop choroidal effusions. The primary tube versus trabeculectomy study, around 10% of trabeculectomies develop choroidal effusions. Another not infrequent complication is bleb leak, which happened in 12% of people in the primary TVT study. There's also been innovation in glaucoma drainage device implants, with a variety of materials trialled in the early 20th century. In the 1950s saw the first plastic glaucoma drainage devices, and now we have a range of valved and non-valved tube and plate devices available, including the Barvelt tube, the Amid valve, and the Paul glaucoma implant. Traditional tubes, like the Barvelt tube, do have some limitations. Because of their size, they lack any intrinsic flow restriction, so early post-operative hypotony can be a problem, so measures need to be taken like intraluminal stent sutures and external ligatures. And then there can be late failure due to fibrosis, wound healing around the plate, and their large diameter within the anterior chamber increases the risk of corneal endothelial cell loss. The recently introduced POR tube has a smaller external diameter, so may be better for the corneal endothelium. It also has a smaller lumen, but it still lacks significant intrinsic flow restriction, so still requires an intraluminal stent suture. However, according to Poiseuille's equation, it is possible to design a tube that has enough inherent flow restriction to minimize the risk of hypotony. This equation is used to calculate the relationship between the length and diameter of a tube and the pressure drop across it. The outflow resistance is linearly related to the length of the tube, and the pressure differential across the tube decreases to the fourth power of the radius of the lumen of the tube. Making use of this equation, two devices have been introduced, first the Zen and more recently the PreserFlow. The first iteration of the Zen was the Zen 45, which had a 45 micron lumen and 220 micron external diameter, and more recently we have the 63 micron Zen, which has a slightly larger external diameter. The PreserFlow has a 70 micron lumen and a 350 micron external diameter. This table shows some of the other differences between the different devices. So the tube length, for example, for both iterations of the Zen is 6 mm compared to 8.5 for the PreserFlow. The intrinsic outflow resistance is around about 6 mm of mercury for Zen 45 and for PreserFlow, but lower for the Zen 63. And of course that refers to just the resistance across the tube. As healing occurs, there'll be resistance that builds up, that adds on to this within the tenons, within the conjunctiva. And the material is very different. So the Zen is made of a porcine gelatin, whereas PreserFlow is made of SIBS, which I'll mention more in a moment. So the Zen can be delivered ab interno or ab externo. With the ab interno approach, there's a 27 gauge delivery system, which is passed through a self-sealing corneal incision, normally about a 1.8 mm incision. It's passed across the anterior chamber through the angle, and then it emerges 3 mm from the limbus under the conjunctiva, and then a slider is used to push the Zen forward and leaving the Zen in place. The ideal placement of the Zen is 3 mm under the 3 mm length of it underneath the conjunctiva, 2 mm intrascleral and 1 mm in the anterior chamber. And prior to the delivery, mitomycin C is injected intratenons, normally at a concentration of 0.1 to 0.2 milligrams per mil, and far away from the limbus to try and reduce the risk of an avascular bleb. So it's a quick procedure. It can also be done ab externo with a peritomy. Last year we had the results of the first randomized control trial looking at the Zen 45. This was a non-inferiority study, though there was some differences in the dose and route of administration of mitomycin C. Patients were permitted to have a drop holiday to prepare the ocular surface prior to surgery, and the ab interno approach was taken. So the results: Zen was found to be non-inferior to trabeculectomy, according to the primary endpoint, which was a 20% or more reduction in intraocular pressure, 62% of Zen eyes compared to 68% of trabeculectomy eyes at 12 months. So that is perhaps slightly lower than one might expect for trabeculectomy. And trabeculectomy, though, achieved lower mean intraocular pressures, with the at 12 months a mean pressure of 14.4 with the Zen compared to 11.8 with the trabeculectomy. In terms of safety was good. There were fewer cases of hypotony with the Zen, but there were a higher proportion of people who had an increase in IOP compared to baseline. There was also a large proportion of people who needed post-operative interventions, so 23% of the Zen patients needed needling, 18% of trabeculectomies, and the Zen patients were more likely to need a secondary glaucoma surgical intervention. In terms of Zen 45 complications, there was a systematic review published recently, though this did include retrospective case series, so it wasn't the best quality. The complications were infrequent, but there were patients who had bleb leak, hypotenuse maculopathy, and even endophthalmitis, and implant exposure. Now, these were rare, but bleb creating procedures are not minimally invasive. And overall, Zens are associated with a high needling rate and a potential for thin avascular anterior blebs. The Zen 63 has recently been introduced, and there's already quite a few studies evaluating this, and the hope is that this might give more flow and a lower needling rate without added risk of hypotony. So what about the PreserFlow? PreserFlow was CE-marked in 2012. It's made of SIBS, which is a soft, flexible, highly biocompatible material. The procedure is ab externo. It involves a peritomy, sponges of mitomycin, and then making a small needle tract with a 25 gauge needle into the anterior chamber. The Presiflow is then inserted through this tract, and the Presiflow has fins on it which are wedged into the tract to prevent migration. Some people suture the Presiflow to the sclera, and occasionally people use a intraluminal stent suture, either 9-0 or 10-0, to try and further reduce the risk of early postoperative hypotony. So what's the evidence for the Presiflow? Well, we have the 2-year results of a randomized multi-center study published, which compares Presiflow to trabeculectomy. Of note, a lower concentration of mitomycin was used in this than is typical. Overall, Presiflow had a higher proportion of people failing at 2 years compared to trabeculectomy. The reasons for failure: in the trabeculectomy group, it was more common that failure occurred due to low pressure, whereas in the microshunt, due to high pressure or needing reoperation. The trabeculectomy group also achieved a lower mean IOP at 10.7 at 2 years compared to 13.9 for the Presiflow. The corneal endothelial cell counts, though, over time were similar between groups. In terms of safety, low pressure complications were less common with the Presiflow group. However, they still occurred. So, for example, 4.6% of Presiflow patients had choroidal effusion versus 6% of trabeculectomies. So to summarise Presiflow, it has an innovative design. A longer tube gives a more posterior bleb. It has intrinsic flow resistance and a low endothelial cell loss. Though you do need a high dose of mitomycin due to the intrinsic flow resistance, there's a lower risk of low pressure complications. It provides greater efficiency and reproducibility. The European Glaucoma Society has recently produced a guide on surgical innovation, and an important point that they make is that only the ab interno non-bleb forming surgeries can really be defined as minimally invasive. If you're creating a bleb, it's not really a minimally invasive procedure. They also made some recommendations on bleb forming procedures, which included things like mitomycin should always be used to inform patients that bleb manipulations are often required. And they also have a section, choosing wisely. One of the things that it says we should avoid is we shouldn't use bleb forming surgeries if we don't have prior training and experience in bleb management. So I hope you found that of use and that you now have a better idea about the evidence for these innovative bleb forming procedures.
Well, thank you very much. And very, very interesting talk by Andrew Tath. And now the next speaker is from Spain, José Belda. He will talk about laser techniques, Eagle from Belkin Vision and December laser from Helios. Okay, go ahead. Please.
Thank you very much for the invitation to speak today. Here.
Thank you very much for the invitation for the ARI. My name is José Belda. This is my background. I'm a glaucoma specialist, but I also do cataract surgery and refractive surgery. We're going to focus only in those cases of early glaucoma in which we can use the lasers, and this is the aim of these lasers, to reduce the pressure in ocular hypertension, mild and moderate glaucoma. When we talk about glaucoma care all over the world, there are much more number of patients that specialists that are prepared to treat these patients. And when we talk about the different lasers, we have lasers that do photothermal, like the ALT, which is not used anymore. We can also use the JAK laser for peripheral iridotomy. But we're going to talk about the photochemical lasers like the SLT or DSLT, or we're going to talk about the photoablation lasers like the examer laser for glaucoma, which is called also Helios. When we talk about Helios, we have to say that this laser has to be used intraocularly, doing probably combined with a cataract surgery. It can be also done as a standalone procedure, and we're going to create like 10 trabecular microchannels that will help to reduce the outflow resistance of the aqueous humor and reduce the pressure with this treatment. And the good thing about this treatment that it doesn't need a prosthesis, is not going to leave any device into the eye. This is the console in which we can do the laser. It's a solid-state excimer laser. It's very easy to be done, and it has to be used sterile, and it's going to be a probe that's single use. This is the microchannels that we can obtain with a laser. You can see that these microchannels are obtained in the trabecular meshwork. This is a nice picture from Dr. Moreno Valladares from Albacete, in which we can see that 31 months after the laser, the patency of the channels are still there. And this is a nice animation in which we can see this trabecular meshwork treated with the laser and how the channel is created to reduce the resistance for the outflow. This technology has proved to be useful even 8 years after the surgery by reducing the pressure 20% from the pressure previously to the surgery, and up to 80% of patients are medication free. This is a case that I treated in the beginning, one of my early cases. You can see the probe. We have to position it normally using like a diamond that is in the cover, so we can know that it's in the proper position. And this is how the channels are created. We can see that you have to gently touch the trabecular meshwork without pressing it, and creating these microchannels every time we press the pedal to do the treatment. You can see that there are some bubbles from the disruption that are created with the laser, and that after the 10th treatment, the probe is over. You cannot use it anymore. This is another nice picture by using the intraoperative OCT. You can see that in the left picture, in the left video, we're using the probe to create the channels, and in the right you can see with the intraoperative OCT how we create the channel, and how there is like a plume coming out of the channel, and also the bubbles that are coming out after the treatment. This nice technology, which is the intraoperative OCT, allows us to see that we are doing the treatment in the correct place and the channels have been created. Talking about the patient selection, we normally use this treatment in mild to moderate primary open-angle glaucoma and in patients that have just 1 or 2 drops to control the glaucoma. There are some tips, as I already told about them, but it's very important to have a good position of the head of the patient, good position of the microscope. You have to be very comfortable to do the gonioscopy. You have to be a surgeon that are used to do this type of treatments using the gonioscope lens. And talking about the treatment, it's going to be the same treatment that we use for the cataract surgery. There is no changes about that, and you have to not to be worried if there is some hyphemia coming afterwards. When we talk about SLT is now on fashion again, as long as there was a delayed trial that said that this should be the first line treatment for most of open-angle glaucoma. But we're going to talk about the SLT and how it works. DSLT is a technology also known as Belkin, and this laser is going to do the SLT but with no use of a lens. We're going to do it through the limbus and not through the cornea. The comparison between both procedures, we have to take into account that the delivery of energy is going to be slightly different, and we need more energy when we use this system, as long as it has to cross the limbus. You can see here that it has to cross the limbus, and it has to require more energy for that. The procedure is quite simple. We have to do probably the same as with any SLT, but the difference is that we're going to use a speculum before using the treatment, and the post-op controls are going to be also very similar to those that we use in SLT. The possible side effects are the subconjunctival hemorrhages, very minimal, or the possibility of having a spike of IOP. And probably, so this is how the system works. This is courtesy of Professor Sharadaya. You can see that the eye speculum is inserted in the eye of the patient. They've used some topical anesthesia. The patient just put his head and forehead against the strip. The doctor is going to focus the eye, and with some very simple adjustments, the system is going to recognize the limbus of the patient, and we just press the button to treat, and the treatment is nearly done, and it's done, and this is how it works. This is what the advantage of the SLT is, which is we can treat more patients, it can be repeated anytime, and we can have maybe an assistant doing this laser for us. So if there is any questions, I would be very welcome to help you with all of them. Thanks very much.
Okay, thank you very much, Jose. Very interesting topic, because this is a new technology that will have, in my opinion, an important role probably in the future. And now we have the debate that will be led by José Martínez de la Casa, and we have Lucía Rial and Julián García Feijó on the debate panel. And I want just to mention two issues that have been coming from the audience, because the audience are cataracts mostly. And number one, which are these technologies, the ones that you really indicate for those cataracts that have not been practicing as the more accessible and easygoing ones? And the second question is about the blood-forming mix and the use of maltomycin C, because before, trabeculectomy was considered dangerous because of the use of maltomycin, that it has very well-known complications, and now it seems that we are using higher concentrations and repeated times injecting subconjunctival or maltomycin C, which indeed should be taken into the consideration as far as the risk factors. So these two questions are open to the debate, and José Martínez de la Rosa will conduct this. Thank you, José. Thank you.
Thank you, Jorge. Thank you for all the speakers for the excellent presentations. We have now the debate. And if you want, we can start with the first question of Jorge about if there's any room for cataract surgeons with all these techniques, trachea mix, minimal invasive blood surgery. Do you think there's a room for the cataract surgeon to perform these techniques? Any of you? Julián, for example?
Well, yeah, I think so. So if we are thinking of cataract surgeons, probably mixed surgeries with trabecular implants, so ISTEN or ELT even, are the most appropriate. So the easiest ones to do and the safer. So if you are a cataract surgeon, my recommendation is learn how to do one of these mix combined with an implant, and maybe the techniques that are one of the techniques without an implant.
Carlos, you have talked about these devices. What do you think about it?
Yeah, absolutely. So I agree totally with Julián here. I think when it comes to mix, as Andrew said, pure mix, so minimally invasive, we're not talking about blebs here. I think that cataract surgeons should be doing that, because cataract surgeons have access to a lot of people with glaucoma, very early glaucoma, people who are just ocular hypertensives but have drops. And it would be a shame if actually they weren't offered the opportunity of having a stent, or perhaps a mix without a stent that could get them off drops, or maybe lower their pressure a little bit more, or prevent them from having progression in the future. So I, as a glaucoma person, I have absolutely no problems with cataract surgeons doing these, doing mix, combining phaco with mix, for example. I think it will keep some patients away from coming to to us for the bigger stuff. I think it's suboptimal in today's age to have a patient on drops for a very early glaucoma and not at least offering them a mixed device of whatever choice you have.
Pepe?
Okay, I agree, but I think that the keystone of this is the indication. I think that the cataract surgeon has to be aware in which patients these devices or this surgery can really work, or in which patients this is not going to work and it's going to be a loss of time. And time is precious in glaucoma. So if you delay a treatment for glaucoma in a patient that really needs it, for example, a filter surgery or a tube, then you might lead to the blindness. So in my opinion, I think that education and also information for cataract surgeons is mandatory if they are going to start treating early glaucoma, because we cannot miss those patients that are going to progress and they are going to be severe glaucoma in the future.
Mm-hmm. And what about the other question that Jorge asked us about the mitomycin C? Which dose of mitomycin you routinely use in minimal invasive bleb surgery, and some tips to use safely?
Well, mitomycin is only used when we are going to create a bleb. So depending on which procedure you're going to do, you're going to decide the dose of mitomycin and also the time that you're going to apply the mitomycin on the conjunctiva. I think that right now there is a debate about the concentration, even among glaucomatologists, because for some of these devices, like the pressure flow or the Shen, they are proposing that the dose should be higher, and it would be 0.04 instead of 0.02 in order to achieve a better control of the fibrosis. In our department, we're using for pressure flow 0.04% in all cases, with a better result than when we were using the 0.02%. But this is not applicable to the rest of the filtering surgeries.
I think I agree with that. I think we have to be careful with the terminology with some of these innovative glaucoma surgeries, because sometimes we use the term MIGS and we lump everything in together under that big umbrella. But it's the bleb forming procedures, though, definitely aren't minimally invasive. If you make a bleb, there is a risk with creating a bleb, and one of those risks is through the use of mitomycin, and with Zen in particular, we do sometimes see quite thin avascular blebs. And I think a lot of it has to do with where the mitomycin C is placed. So I think if we place the mitomycin a long way away from the limbus, then it's a safer place for mitomycin to be. But these surgeries, Zen and PreserFlow, they won't work unless we use antimetabolites, because they're designed to have restriction to flow with the length of the tube, the lumen size, so which reduces the risk of hypotony. But then if we just put them in and we don't use any kind of anti-metabolites, we don't try to stop wound healing, then in the majority of people, they're not going to work. So we have to use them, but we have to be very careful how we handle the mitomycin, because there are risks. And I think that's one of the reasons that these surgeries are best for people who have experience with that, have experience in trabeculectomy or other bleb-forming procedures. It's very different to the canal-based mixed procedures. And I think for cataract surgeons as well, the nice thing about the angle-based mix is that when you do a phaco, they work better. They're synergistic. Whereas with the bleb-forming surgeries, they're not ideal to combine with cataract surgery, because the chance of them working will be less, because there's more scarring, there's more flare in the anterior chamber, more wound healing.
So I think Andrew answered the second question really, really nicely. That basically, of course, it's a completely different group of surgeries, and also the surgeons doing them should be different. So in answer to Professor Alio's question, yes, we've moved away, still not completely from TRABs. I wouldn't want to not be able to do TRABs, because I think it's important. But it doesn't mean that now everyone can do PreserFlow and Xen, because there's a lot of extra stuff which goes with antimetabolite. My point that I wanted to say is a very interesting piece of work we did with Alessandro Rapiolo is about whether applying mitomycin with sponges or by injection makes a difference, because many people feel that maybe injecting mitomycin rather than applying it directly causes more of these avascular blebs Andrews talks about. And looking at all the literature available worldwide, actually there's no difference. So actually injections of mitomycin aren't as bad as maybe people think, but Andrew's absolutely right. It's about where you place that mitomycin, whether you inject or use a sponge. And that is definitely something in the realm of the glaucoma surgeon more than the cataract surgeon, probably.
Mm-hmm. Okay. Lucia, any comment about this?
Yeah, I want to make emphasis in two important things that we have explained or said during the discussion and the session. One of them, in relation with mitomycin, of course, SEN or pressure flow is a bleb surgery, and bleb surgery needs a bleb management. So it's really important if you want to perform that surgery that, thanks God, every time we have easier, quicker, and more representative surgeries that we can do. Everyone, it's easier than do a trabeculectomy or deep sclerectomy, but as important as the surgery is the postoperative care. So we need to know how to manage the bleb to have a good result. Another important thing is that difference between the mix and bleb surgeries, because the European Glaucoma Society says that mix only can be that procedures that are ab internal and not bleb forming procedures. So that makes that difference, and we have to be conscious that it's not the same.
Mm-hmm. Okay, if we talk about angle closure glaucoma, the role of lens extraction is crucial. So in which cases do you recognize to do the cataract alone surgery, or in which cases do you combine with any glaucoma surgery? What is the profile of the patients to choose between the cataract alone or a combined surgery? Any of you? Julian, for example?
Okay, so it's me again, the first. Great. So, well, I mean, in general, if possible, it's just the cataract surgery. So unless the glaucoma is very, very advanced and the pressure is really high, and there is lots of synechia, my recommendation is do the cataract surgery first, see what happens with the IOP, and then decide. Because even if they need later a filtering procedure or a bleb forming device or whatever, the conditions and the safety of the glaucoma surgery is much better than if you do a combined.
Mm-hmm. Any other comment on this topic? Andrew, for example?
Yeah, I think we should remember most of the mixed procedures, they're licensed for use in open angle glaucoma. Now that doesn't mean, we do things off label sometimes, don't we? And they can work well in angle closure, but sometimes it's hard to know post-operatively, was it the phaco or was it the MIGS that had the effect? And I think they're not all devices are the same. So if you have a narrow angle and you do the phaco, quite often the angle will open, but that isn't always the case. Sometimes you have somebody with an anteriorly positioned ciliary body. There might not be space for like a big device, like a hydrus, for instance. So I think in general we can get powerful IOP lower in angle closure just by removing the lens. So my default is for angle closure is just do the phaco.
Yeah, I'll go back to what Jose Belda said before. I think it's about education as well, because it's sometimes a little bit dangerous if people think there might be a more complex case, maybe it's angle closure in this example, and maybe just try a MIGS and see what happens. And that is quite a dangerous way of thinking, because I've seen a lot of patients where that decision is made and then the pressure is still very high, and then patients have had damage to their nerve and come with worse vision, and you're a little bit stuck into what to do next. So I think it's really, really important to know what, of course, as Andrew's saying, the indications really are. And of course, we push boundaries, we always do. And in some cases, with some reasoning, we can push those boundaries, but it's really important to really see what are we trying to achieve here, and rather than just do something for the sake of doing something, think really what we're trying to achieve. And especially when it comes to combining the angle closure patients, when would you try and combine and not just do a phaco? I think it's those patients who have a very, very significant cataract and also very advanced glaucoma with uncontrolled pressure. Those are the most difficult, I find, because you need to get the cataract out, but you also know that they have uncontrolled pressure, and that whatever combination you do has potentially less risk of success. Because combining anything, a phaco-trab, a phaco-xen, the risks of failure, of bleb failure are higher, and probably a phaco-mix is not strong enough in those patients with advanced disease, high uncontrolled pressures on maximal treatment, and a stinking cataract.
And talking again about the trabecular devices and trabecular surgeries, we have a lot of them. We have the iStent, we have the Hydrus, we have the ab internal canaloplasty, we have the Helios. So how do you decide which technique you use in these mild glaucomas combined with cataract surgery? How you decide? Is only a surgeon preference matter, or any other option to decide which options you choose for your patients?
I think it's unfair for Julian to start, so let me start myself. So basically, it's a really good question, and it's kind of impossible to really answer, but of course we go by experience. We go by what we believe in, we go by what we have available. So every country is different. I was in the UK, now I'm in Germany. There's different codes, there's different remuneration. So you're also guided by that in a way. You can also argue there are patients who specifically, for example, don't want a foreign body in the eye, and then you would choose a non-device mix as opposed to a device mix. There are different types. The younger patient, potentially with a trabecular meshwork problem, myocylindrine mutation, then removing trabecular meshwork or just bypassing the TM is enough, as opposed to having to do more. So it's quite tricky there, and it depends on really what you're trying to achieve. What we lack is a test that shows us, as again Jose said before, which patients will do well and which patients won't, before we actually put them on the table. That is lacking right now, and that is the holy grail of MIGS, in my opinion.
If I may say something, so stressing what I said at the beginning, so probably you have to learn at least one technique of an implant, so Hydrus or iStent or whatever is available in your country, and then at least one implant-free technique, so maybe whatever, so iTrack, Omni, ELT, so you have this potentially, you have more options for a specific patient. And Carl was very, very right when he said, depending on the type of glaucoma and the age, is very important. You may use, I mean, for a juvenile glaucoma, probably, Hydrus or iStent doesn't make any sense. But maybe a procedure that rips the trabecular meshwork, maybe you should consider at least the possibility if it's an early stage glaucoma.
I would like to add also that in terms of efficacy, I think that all these procedures are exactly the same, because they are they depend on the epivenous pressure. So it doesn't matter if you are using probably iStent or Hydrus or Helios, whatever. You might find that the amount of pressure that you are going to obtain in reduction is going to be very similar among all these procedures. And this is because the epivenous pressure has a lot to say about these outcomes. So I think that the surgeon has to choose whatever is available, he's comfortable with, and talking about the differences, you have to know that in some procedures you have more chances to get an outcome than with others that you have just 1 or 2 chances to get an outcome.
Usually these patients are mild glaucomas, so you prioritize the safety over the efficacy, or it's another factor to consider?
I think there are some potential differences in safety between the implant procedures and the implant-free procedures. If you're doing a 360-degree trabeculotomy, for instance, to me, I mean, that probably has a slightly higher risk than putting in a small implant or using a laser like ELT to make a small bypass in the trabecular meshwork. But perhaps, we don't know, but perhaps a 360-degree trabeculotomy gives you more powerful IOP lowering. And I think it's exciting because over the next few years, we're going to have more studies that actually compare the different procedures, because most of the studies to date have compared phaco alone versus phaco plus a mix. Which is shown that it's better than phaco alone, but we do need more studies comparing the different procedures and helping us to decide on case selection a little bit more clearly.
Okay, and moving to the minimal invasive left surgery, is the SEN and pressure flow are a real alternative to trabeculectomy, to trabeculectomy, sorry. Do you think that it's still a role for a trabeculectomy? So it's the two questions. It's a real alternative to trabeculectomy.
Shall I go first on that one then? Yes, it is an alternative, but sorry, you asked two questions in slightly different ways. So is it an alternative trabeculectomy, a real alternative? Yes, in some patients. So there are some patients where I would have done a trabeculectomy and now I don't because I do a PreserFlow instead. And in fact, there's quite a large number of people. But is there still a role for trabeculectomy? I would give a very strong yes to that as well. And there are some differences of opinion about that. But for instance, when might we do a trabeculectomy? What if we have a person who has advanced glaucoma who needs a pressure of 10, needs a really low pressure? Still, the surest way to achieve that is a trabeculectomy. Well, what if we have a patient with normal tension glaucoma who also has a very low target pressure? I think a trabeculectomy there again has the better chance of getting the pressure down.
Let me say something about that. I think that there is a role also for deep sclerectomy, which can achieve very lower teens in pressure, exactly the same as trabeculectomy, and in my opinion, with less complications.
Well, for example, how it's changed the indication and the surgery in your place compared with a few years ago in terms of filtering surgery with the introduction of the new minimal invasive left surgery?
That was a question for me, sorry, Jose, right?
Yeah, Carl.
Yes, I mean, so you guys know I'm a deep sclerectomy guy as well. So for me, the advent of bleb-forming devices was initially quite scary in a way because being a deep sclerectomy surgeon, I thought, my job's over, I'm done. But I still do more deep sclerectomies than I do bleb-forming devices. Having said that, I do a lot of bleb-forming devices as well. So now actually it's quite nice for me because I've got, as Andrew's saying, the normal tension glaucoma patients will get a trabeculectomy. But as Jose is saying, I still can get very low pressures with a deep sclerectomy. So if my target pressure is maybe 11, 12, I'll do a deep sclerectomy, not a trab. But there are patients who need a pressure of 13, 14, and they might not want or have the ability to withstand half an hour of surgery. And then I would consider a bleb-forming device, which, sometimes can be done very, very quickly, and there's not much aftercare with. And patients, for example, after Xen or PreserFlow especially, have very posterior blebs where, for example, I don't know, patients who need multiple intravitreal injections. I don't like having big blebs for my retinal colleagues because they just inject without looking. So having a very, very posterior small bleb like a device can produce for you is quite nice. So I'm lucky to be able to go for all three options.
Okay, Jorge, do you have any comment or do you want to close the session?
Yes, when I want to make just one question before closing, and I want only one word from each one of you. Now you have a cataract surgeon, not expert in these techniques. Which is the one chosen between the one bleb-forming and non-bleb-forming that you recommend to start with? Starting with Jose Belda.
I would say that no bleb-forming procedures for cataract surgeons. none of them.
Yeah.
And for non-blood forming, I would say that iStent or Helios. That would be my recommendations for cataract surgeons.
Okay, Carl Marcirca?
I would probably say the same. So I think iStent, Helios is also very, very easy, and there's no stent to drop in the anterior chamber, but I would go for iStent because you said only one word. If you force me between the two blood-forming devices, I'd say Xen, because you can internal. It's less invasive, so I'll go for Xen if I have to answer that question. But I'd rather have someone who has experience with mitomycin.
Very good. Andrew?
iStent or Hydrus, and no blood-forming procedure.
Very good. And now let's go to the debate speaker, Julian.
Okay, iStent and no blood forming.
Oh, very good. Okay, Lucia.
And again, iStent and no blood forming.
Okay, and finally, the chairperson, José Martínez de la Casa.
Yeah, I completely agree. No blood forming, because the surgeon has to manage the blood, even with the same that doesn't finish when you do the surgery. You have to manage the blood in the postoperative period, and with the trabecular devices, I think the iStent, the Helios, would be the one with a shorter learning curve, and I think the efficacy is well demonstrated with a long-term follow-up studies. So I think it's a very good option for the cataract surgeon.
Okay, I can summarize. So the blood forming for glaucoma specialists, non-blood forming for cataract surgeons. Do you agree? Consensus? Okay, good. Very good. So thank you very much. It was very nice, because this is a frequent problem. I'm very curious about the future evolution of the laser techniques that definitely looks very attractive and minimally invasive, even less invasive because they are external. But I think this is a totally different debate, okay? So I think that, first of all, thank you all of you, because to have this distinguished panel of glaucoma specialists is exceptional. Second, because you have provided very important information for the cataract surgeons. And second, because you provided finally a guideline about what to choose, and then is the decision of each one of the surgeons, depending on the experience, talent, and surgical skills to decide. So thank you very much for your very kind attention, and I want to invite you to the next year. Probably glaucoma is an endless topic. Thank you very much, and we're going to close the session. Thank you, Jose, for your very nice leadership. Thank you.
Thanks,